Have you ever noticed maybe tiny red or purple spots on your pet's gums? Or perhaps on their belly? Or maybe you've just had blood work done,
Yeah.
and the vet mentioned a low platelet count.
Right.
That condition, it's called thrombocytopenia. And it sounds maybe like a small detail, but honestly, it's absolutely crucial for figuring out what's really going on with your dog or cat.
It really is.
So we've done a deep dive into a whole stack of sources, articles, research, clinical notes, all about this condition. Our aim, basically, to pull out the key info you need, help you understand what low platelets mean, why that number might drop, and how vets kind of piece the puzzle together.
Yeah, and thrombocytopenia, it's something we see, well, remarkably often in veterinary practice, shows up on routine blood tests all the time.
Really?
Oh, yeah. And what's interesting, like you said, it's this whole spectrum. It can be just a mild lab finding, maybe not a big deal, or it can be, a life-threatening emergency. And the sources we looked at, they really hammer home the need for a systematic approach. You almost have to be a detective to figure out the why behind that low number.
Right, the underlying cause. And that's exactly where we're heading today. We'll start with the basics, like what are platelets? What's their job? Then we'll get into the different reasons their numbers can plummet, how vets investigate those possibilities, and finally, what treatment looks like once you find the cause.
Sounds good.
Think of this as maybe your shortcut to understanding this really common but sometimes pretty confusing blood issue. Let's get into it.
Okay, all right. So let's talk platelets. The stars of the show. Right. Now, these aren't actually full cells. They're tiny fragments. Yeah, produced way back in the bone marrow. They come from these much larger cells, megakaryocytes. And they just circulate in the blood for, maybe 5 to 10 days or so.
What?
Their main job, it's in something vets call primary hemostasis.
Primary hemostasis. Okay, that sounds a bit technical. What does that actually mean for, your pet?
Right. So, essentially, primary hemostasis is the body's first line of defense against bleeding. Simple as that.
Okay.
When a blood vessel gets injured, platelets just rush to the spot, they stick to the damaged wall, and they clump together. They form this temporary plug.
Ah, like the first responders.
Exactly. They're like the initial Band-Aid, stopping the immediate bleeding.
Yeah.
They also help stabilize the final clot that forms a bit later. So if you don't have enough functional platelets, well, that initial plug just won't form right.
First responders for cuts and bleeds. Thrombocytopenia itself is just having a number below the normal range. Is that it?
That's exactly it. Now, the normal range, it varies a little bit, by species, by the lab doing the test.
Sure.
But generally, you're looking at well over, say, 150,000, maybe 200,000 platelets per microliter of blood for both dogs and cats.
Okay.
And the sources, they often grade the severity, which kind of gives us a clue about the bleeding risk.
How does that work?
Well, grade 1 is just slightly low. Grade 2 is moderately low. Grade 3 is significantly low. And then grade 4, that's severely low. Often you're talking below 25,000 platelets.
25,000. And that's when you really start worrying about that spontaneous bleeding, those little spots we talked about.
That's generally the threshold, yes. Though, the sources are careful. These are guidelines, not hard and fast rules. But yeah, spontaneous bleeding typically becomes a concern when the count dips below about 50,000.
Okay.
And severe, potentially life-threatening bleeding, that's more likely when you're down below maybe 10,000, 20,000. But it's not just the number. Platelet function matters too. Blood vessel health, other clotting factors, they all play a part.
Right. It's complex.
And interestingly, cats, they seem to tolerate lower platelet counts with less spontaneous bleeding compared to dogs.
Huh. Really? That's surprising. Okay, so we know what they do, what a low count means, but why? Why does the number drop? The sources seem to break it down into a few main categories, right?
Yeah, exactly. The first big bucket is decreased production. Think of it like the factory, the bone marrow just isn't making enough platelets.
What would cause that?
Well, it can happen if the bone marrow itself is damaged, maybe by certain medications, some chemotherapy drugs, obviously, but even some common antibiotics can do it sometimes.
Wow.
Toxins like lead, maybe radiation or infections. Tick-borne diseases are a big one, Ehrlichia in dogs, for example, or viruses like FeLV or F5V in cats. Those can suppress the bone marrow.
Okay.
And cancer, too. Things like leukemia or cancer that's spread to the bone marrow. It can basically crowd out those megakaryocytes, the platelet-making cells.
Gotcha. So something's wrong right at the source, in the factory. What's the next reason for a drop?
The second main reason is increased destruction. So the bone marrow is pumping out platelets just fine,
Okay.
but they're being destroyed or removed from the bloodstream way too quickly, often by the body itself.
Oh.
And this is where immune-mediated thrombocytopenia, or IMT, comes in. The sources really highlight this as the most common cause of severe thrombocytopenia, especially in dogs.
IMT.
Hmm.
Is that like an autoimmune disease then, where the body attacks itself?
Exactly that. In what we call primary IMT, the body's own immune system just mistakenly flags the platelets as foreign invaders and attacks them.
Okay.
But sometimes IMT is secondary, which means it's triggered by something else entirely.
Like what?
Like infections again, things like Ehrlichia, Anaplasma, Babesia. Certain drugs can trigger it, sometimes vaccines, even underlying cancers. Basically, the immune system gets all fired up dealing with that primary problem. And then it kind of turns its attention, mistakenly, onto the platelets.
Okay, that's a really critical difference, the body attacking itself versus being triggered. What about the third mechanism?
That would be increased consumption. This means the platelets are just being used up too fast because there's excessive clotting happening somewhere in the body.
Excessive clotting.
Yeah. The classic example here is a condition called disseminated intravascular coagulation, or DIC.
DIC.
Yeah, it's a really severe, very complex situation where you get this widespread, inappropriate clotting happening throughout all the tiny blood vessels.
Wow.
It just chews through platelets and other clotting factors at an alarming rate, which, paradoxically, actually leads to bleeding because the body runs out of everything it needs for normal clotting.
DIC sounds like a really major emergency.
Oh, it absolutely is. And it's never a primary disease itself. It's always a complication of some other severe underlying problem, like overwhelming infection, sepsis, or major trauma, heat stroke, even advanced cancer.
Okay.
Other things can consume platelets rapidly, too, like massive blood loss, obviously, or something called vasculitis, which is inflammation of the blood vessel wall.
Okay, that makes sense. And there was a fourth mechanism mentioned?
Yes, sequestration or redistribution. Bit of a mouthful.
Yeah.
It just means platelets get trapped somewhere. Most commonly, this happens in an enlarged spleen, splenomegaly.
The spleen.
Right. If the spleen gets significantly bigger, it can just hold onto a large chunk of the circulating platelets. This usually doesn't cause super low counts, though. Rarely drops below 50,000.
Okay.
Things like sepsis or even just being really cold hypothermia can also cause some temporary trapping, especially in the lungs.
So to recap.
Yeah.
Decreased production, increased destruction, increased consumption, or being trapped somewhere. That covers the actual low counts. But the sources were really clear about something else. Something that looks like low platelets on the machine report, but isn't.
Yes. Pseudothrombocytopenia. Absolutely vital to know this one, especially with cats.
Pseudo.
So, false.
Exactly. It's an artifact.
Yeah.
Meaning the machine thinks the count is low, but it's actually perfectly normal.
How does that happen?
It happens when platelets clump together in the blood sample tube. Often it's because of the anticoagulant used EDTA is a common one that can cause it, especially in cats.
Right. So the automated counters, they either read these big clumps as just one single platelet, or they just ignore them completely. Either way, the number they report is artificially low.
So this isn't actually a problem with the pet at all. It's a problem with the sample or how it's being read.
Precisely. And that's why the very, very first step any vet should take when they see a low machine platelet count, particularly in a cat, is to confirm it manually by looking at a blood smear under the microscope. You can actually see if the platelets are clumped up, often near the edges of the smear, and you can estimate the true count visually. If you see clumping, then just collecting the sample in a different type of tube, or even just making a smear directly from a fresh drop of blood before it goes in the tube, can often fix it.
Okay.
The sources really, really emphasize this. Always confirm a low machine count manually.
That is such a crucial diagnostic point right there.
Oh.
Okay, so speaking of diagnosis, let's imagine someone brings their dog in. They've noticed some, concerning signs. What might those signs actually be?
Well, the signs are primarily linked back to that failure of primary hemostasis we talked about, basically, signs of bleeding.
Okay.
As the sources explain, with mild or even moderate thrombocytopenia, say, grade 1 or 2, you might not see any obvious signs at home at all.
Really?
Yeah, maybe just increased bleeding during a surgery or perhaps bleeding a bit longer than usual from an injection site. But as the count drops further, especially down into that grade 4 territory, below 25,000, that's when you typically start seeing those clinical signs of spontaneous bleeding.
And the classic sign you always seem to hear about?
Petechiae. Definitely.
Yeah.
These are tiny, like pinpoint-sized red or purple spots, little dots of blood.
Where do you see them?
Usually on the mucous membranes, so check the gums, the whites of the eyes, or on the skin itself, especially in areas where the skin is thin, like the belly or the inside of the ear flaps.
Okay.
And they don't blanch, meaning if you press on them, they don't turn white and then pink again, they stay red.
Oh.
Larger, flat bruises, those are called ecchymoses. Both of those are real hallmarks of a problem with that initial platelet plug formation.
Okay. Petechiae and ecchymoses. What else might someone notice?
You might see nosebleeds, epistaxis is the term, blood in the urine, which is hematuria, or blood in the stool.
Okay.
Now, blood from high up in the GI tract, like the stomach or small intestine, it gets digested and looks dark and tarry. That's called melena.
Melena, right. Yeah.
Whereas fresh red blood in the stool, that's hematologic, usually from lower down. You might also see bleeding from the gums, or sometimes even bleeding into the front part of the eye. That's called hyphema.
Hyphema, okay. And if the bleeding is really severe?
Then you'll start seeing signs related to the blood loss itself, signs of anemia, things like pale gums, weakness, lethargy, maybe even collapse in severe cases.
Right.
And sometimes the bleeding is internal, so it's not immediately obvious. Maybe it causes trouble breathing if it's happening in the lungs, or neurological signs if there's bleeding into the brain or spinal cord.
That sounds serious.
It is. And remember, you might also see signs related to whatever the underlying cause is, too. Maybe a fever if it's an infection, or weight loss if it turns out to be cancer.
Okay, so the low platelets themselves cause the bleeding signs, but the root problem can cause other signs entirely.
Exactly.
So once a vet sees these kinds of signs, and they've confirmed the low count with that manual smear check, how do they figure out which of those four mechanisms or which underlying cause is actually the culprit?
Right. This is where that detective work comes in. That systematic diagnostic approach we mentioned is absolutely essential here.
Okay.
So after confirming the count is truly low, some initial screening tests can help point you in the right direction. There's a test called the buccal mucosal bleeding time, or BMBT.
BMBT.
Yeah. It measures how long it takes a small, standardized little cut made inside the lip to stop bleeding. If that time is prolonged, it tells us there's definitely a problem with that primary platelet plug function or number.
Okay, so BMBT checks the platelet plug stage. What about other clotting tests?
Good question. Coagulation tests, like PT and APTT, they evaluate the other parts of the clotting cascade, the factors that form the final stable clot later on.
Right.
Now, with pure thrombocytopenia, where it's just low platelets, these tests, the PT and APTT, are usually normal.
Okay.
If they're abnormal, it points towards a more complicated problem, like that DIC we talked about, or maybe even a genetic clotting factor deficiency.
Got it.
And sometimes we measure things called D-dimers. These are markers of clot breakdown. If they're elevated, that can also suggest DIC or maybe significant clotting happening somewhere specific.
So PT and APTT check the next stage of clotting.
Mm.
If those initial screening tests point towards a platelet issue, or maybe they're all normal, what's the next step? How do you dig deeper for the cause?
Well, comprehensive blood work is pretty standard. A full complete blood count, or CBC, and a biochemistry panel, plus a urinalysis.
Okay.
The CBC looks at all the blood cells. Are other cell lines low too? Like, are the red cells low? Are the white cells low? If everything's low, that's called pancytopenia.
Pancytopenia.
Right. And that strongly suggests a bone marrow problem, meaning decreased production is likely the issue.
Back to the factory.
Exactly. And the biochemistry panel and the urinalysis, they can help uncover underlying organ disease, maybe signs of inflammation or evidence of infection somewhere.
And infectious disease testing, that sounded really critical earlier, especially for things that might trigger IMT.
Oh, absolutely critical. So many infections can either trigger that immune destruction, IMT, or directly suppress the bone marrow.
Right.
Tick-borne diseases are huge offenders, depending on where you live, of course.
Yep.
Ehrlichia, anaplasma, petechiae, those are common ones. In cats, FLLV and FIV testing are crucial.
So you test based on location and history.
Exactly. The sources really emphasize testing for the relevant infectious agents based on the pet's signalment, history, and geographic location. You don't just test for everything randomly.
Makes sense. What about imaging, x-rays, ultrasound?
Yep, very helpful too. X-rays and ultrasound can help identify underlying issues. Maybe an enlarged spleen or liver where platelets might be getting trapped or destroyed.
Okay.
They can also show signs of internal bleeding that you wouldn't see otherwise, or maybe evidence of tumors or infections hidden somewhere else in the body cavity.
But the sources seem to really point to one specific test as often being key. particularly if you suspect decreased production or if the cause just isn't obvious after all that.
You're thinking of the bone marrow aspiration and biopsy.
That's the one.
Yes. This test gives the vet a direct look inside the factory. They collect small samples of the bone marrow fluid, that's the aspiration, and a tiny core of tissue, that's the biopsy, usually from the hip bone or maybe the shoulder.
And what does that tell you?
By examining those samples under the microscope, they can directly assess the number and the health of the megakaryocytes, those platelet precursor cells we talked about.
Ah, okay. So this test tells you definitively if the factory is or isn't making platelets properly.
Exactly right. If you look at the bone marrow and see lots and lots of healthy megakaryocytes, but the platelet count in the circulating blood is still really low, well, that tells you the factory is working fine. But the platelets are being destroyed rapidly after they get released. That points very strongly towards increased destruction, like IMT.
Okay.
On the other hand, if you look in the bone marrow and there are very few megakaryocytes or they look abnormal, that confirms a production problem. It suggests a primary bone marrow disease, maybe a aplasia where it just fails, or myelofibrosis, which is scarring, or maybe cancer that's infiltrated the marrow.
That seems like it would really help narrow things down between that factory problem and the destruction problem, which sounds vital for treatment.
It's often the key differentiating test, yes.
So once the cause is identified, how do you actually treat this? What are the options?
Well, the treatment is highly, highly dependent on that underlying cause. That's the main thing. But if a pet is actively bleeding or if they have a critically low platelet count, the immediate management focuses on just stabilizing them and stopping the bleeding.
What does that involve?
First off, strict rest. Cage rest, usually, to prevent any bumps or injuries that could cause more bleeding. Avoiding any unnecessary injections is important, too, and applying direct pressure to any bleeding sites you can see.
And what about blood transfusions? Are those used?
Oh, very often necessary, yes. Fresh whole blood is great if the pet is also anemic from blood loss. Or you can use platelet-rich plasma or platelet concentrates.
Okay.
These provide functional platelets immediately, although they don't last very long in the body, maybe only hours, up to a couple of days sometimes. But they're crucial for temporarily shoring up that platelet plug while we work on treating the root cause.
Right, buying time.
Exactly. And sometimes medications called antifibrinolytics are used, things like aminocaproic acid or tranexamic acid. They don't make new clots, but they help stabilize the clots that have already formed, make them less likely to break down prematurely.
Okay. Steroids came up earlier when we talked about IMT. Are they used right away in treatment too?
Yes. Often high-dose corticosteroids, like prednisone, are started quite early, especially if IMT is strongly suspected, maybe even before you have a definitive diagnosis back from all the tests.
Why so early?
Because they act pretty quickly to start suppressing the immune system's attack on the platelets. So you want to get that process started if IMT seems likely.
Got it. So that covers the emergency care, stabilizing the patient. What about the longer-term treatment based on the actual cause you find?
Right. So if IMT is confirmed, the cornerstone of treatment is immunosuppression, usually starting with those high doses of steroids, like prednisone.
Okay.
And this treatment typically lasts for weeks, often months, with the dose being slowly tapered down over time once the platelet count recovers.
And if steroids aren't enough? Or if the side effects are too bad?
Good point. Then second-line immunosuppressants might be added. These are other medications that also suppress the immune system, just maybe through different mechanisms, things like zethioprin or cyclosporine. They're used to help get the platelet destruction under control. And in really severe or unresponsive cases of IMT, sometimes removing the spleen, a splenectomy, can be considered, because the spleen is a major site where those antibody-coated platelets get destroyed in IMT.
Right. Takes out a major destruction site. Okay. What if the cause turns out to be an infection? Or cancer?
Then you absolutely have to treat that underlying disease directly. So antimicrobials for the specific infection, guided by testing, of course, chemotherapy, radiation, or surgery for cancer, depending on the type and stage.
Makes sense.
If it was caused by medication, obviously, stopping that medication is essential. And for DIC, the absolute priority is aggressively treating whatever severe underlying disease triggered it in the first place, manage the sepsis, treat the trauma, cool the heat stroke patient, address the cancer.
So it really hammers home that the treatment isn't just about giving platelets. It's almost always about fixing the problem that led to the low count.
That's exactly it. And throughout all of this, supportive care is absolutely key. Keeping the pet comfortable, managing any pain, maybe using medications to protect the stomach lining if GI bleeding is a risk, and just carefully monitoring their condition, watching for any worsening signs of hemorrhage.
Given all these different potential causes
Yeah.
and the different treatments, what's the outlook usually? What's the prognosis?
Yeah, that's the million-dollar question, isn't it? The prognosis is highly variable. The sources make it really clear that it hinges almost entirely on successfully identifying and treating that underlying cause.
Okay. Can you unpack that a bit? Like, what makes a prognosis good versus, say, guarded or poor?
Sure. So, causes that resolve relatively quickly with specific treatment generally have a good to excellent prognosis. Think about drug-induced thrombocytopenia. You stop the drug, the platelets usually come back. Or some infections that clear up well with the right antibiotics.
Right.
Many cases of primary IMT, especially in dogs, also have a good prognosis if they respond well to that initial steroid therapy.
But it sounds like not all cases are that straightforward.
Unfortunately, no. The prognosis becomes more guarded for, say, severe IMT that's really difficult to control, requires multiple drugs, or keeps relapsing, or for chronic infections that are hard to clear completely, or maybe for moderate cases of DIC where you're struggling to control the underlying cause.
Okay. And poor prognosis.
That's often associated with severe bone marrow failure, like from widespread cancer in the marrow or severe aplasia where the marrow just shuts down. Overwhelming sepsis often carries a poor prognosis, as does severe, uncontrolled DIC.
Mm-hmm.
And while thankfully it's uncommon, if there's bleeding into the brain due to very severe thrombocytopenia, that situation is often fatal, so that carries a poor prognosis too.
Right. So it really depends on the why.
It really does. What's definitely clear from our deep dive into all these sources is that finding a low platelet count, well, it's rarely the end of the story, is it?
No, sounds like just the beginning.
Yeah, exactly. It's usually the start of a diagnostic journey. And the absolutely critical step, the main takeaway, I think, is figuring out the specific reason for that low count. That why completely changes the expected outcome, and it dictates the whole treatment strategy you need to help the pet.
Absolutely. And digging into this material, it really does emphasize how interconnected everything in the body is, doesn't it? You know, a single number on a blood test, like the platelet count, it can just be the tip of the iceberg. It could hint at anything from a simple issue with the blood tube,
Right, the pseudothrombocytopenia.
all the way to a really complex immune disease or even hidden cancer. It's definitely not just a number. It's this crucial clue that demands investigation.
Yeah, well said. And we also learned that even though thrombocytopenia itself is a common finding on lab work, severe spontaneous bleeding because of low platelets isn't actually nearly as common in general practice as you might initially think or fear.
It's reassuring, actually.
It is, and it really reinforces why that detailed, systematic diagnostic process, the one laid out in the sources, is so incredibly vital. It lets vets pinpoint the specific issue and manage the risk proactively, hopefully before it escalates into a life-threatening bleed.
Right. So thinking about that, how often thrombocytopenia is really just a sign pointing to something bigger happening underneath? It makes you wonder, doesn't it? What other common abnormalities that pop up on, say, a routine blood test might also be hiding a much larger, more complex story just waiting to be uncovered.
That's a great point.
It really makes you think about all the hidden layers of health and disease that might be lurking within those seemingly simple lab results we get back.